Welcome to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who gets concerned when watching the news and hears the phrase, a new health study shows. I'm Matt Fox, professor of epidemiology and global health. I'm here with Don Thea and Chris Gill from the Department of Global Health.
Howdy.
And we are here in the Boston University Godley studio as always. Before we get started, we want to take a second to remind you about the Population Health Exchange. That is Boston University School of Public Health's research hub for lifelong learning. Find out more at www.pophealthex.org. That's where you'll find this podcast as well as many other population health learning programs and tools. And just as a reminder, please, please, please go onto iTunes or whatever podcast service you use and give us a rating.
We particularly want to hear from those two listeners from Belarus.
And what about the one we as far as we can tell, we have saturated the market in Mauritania. I think we've got Belize. We got several Belize. Togo, that was the one. I think we got 3 listeners in Togo, or at least 3 downloads.
We love it. Send in your reviews, folks.
Shout out to Togo on this.
Go Togo, man.
On this episode of the podcast. But go ahead and give us a rating because that'll help other people find us. And now onto the show. So today in our first segment, which is our Journal Club segment, we are going to get into a study that contradicts most of the research to date on the benefits of coronary artery stents for angina, or it might be an overstatement to
angina.
Say
stable angina.
Stable angina.
Is it really pronounced angina?
Mm-hmm. Angina.
Did not know that.
It is.
Wow. Okay, I learned
for
something.
The cognoscenti.
There you go. And in the second part of the podcast, our deep dive, we will get into whether it is what is ethically justified in medical research. And then in our third segment, our amazing and amusement, we will get into the fun stuff in the research world. Or Don will give us some wacky stuff that we hope is really true, but no one's ever really sure
it really is.
All right, so let's get into it in our first segment. Segment 1, we're going to look at a study that, honestly, it totally blows my mind that they were able to do this for reasons that we will get into. But this is a fascinating study. It was published in the Lancet just recently. The lead author is Rasha Al-Alami, and it was titled Percutaneous Coronary Interventions in Stable Angina.
Angina.
I keep saying that. Angina. You're going to have to correct me through this whole thing. Angina.
Don't confuse him.
It's the Orbita study, and then it says a double-blind, randomized, controlled trial. And so one of the things I found fascinating about this study was if you're signed up for the New York Times alerts, which are normally seem to be only sent out in the cases where there is political news or some country has their president overthrown, actually sent out an alert about this study. So in and of itself, I think that demonstrates that this was a pretty amazing finding. So I'll give you some of the headlines. One said, study, stents no better than medications in stable angina. That was from the Pittsburgh Post-Gazette.
Baguette. That's the French version.
Or is it baguette? I don't know how to pronounce it. Then this one I found is a really strange title for the New York Times. Quote, unbelievable. Heart stents fail to ease chest pain. I don't know why unbelievable is in quotes.
Because this is like gospel.
Unbelievable in quotes, though. Isn't it just unbelievable?
I think they mean it. I think they're not saying we don't believe it. I think they're saying this is amazing.
Okay.
Who knew?
Wouldn't that warrant an exclamation point rather than quotes?
Yeah, I know. It is true. It's bad copy editing, perhaps, on the Times.
All right. And so then to stent or not to stent for chest pain?
No.
That's CBC.
Okay, that gets a single star. I'm sorry. That's terrible. Boo.
Okay, I'm going to stop there then. So Don, can you break this down for us? Tell us what the study design was and what they did and go from there.
Bear with me. This is somewhat of a complex study. So apparently there are about 500,000 stent placements that are done globally.
That is
every
based
year.
on the study?
No.
No,
I mean that figure is based on the study. That's what they cited.
It's cited in the study.
Yeah.
I read some people disputing that number. Maybe
really,
about
it's a lot
half
of them,
that.
It's just a big
still
number.
a lot.
500,000 done for stable angina.
It's wicked huge.
Is that how you pronounce it?
Angina.
And Chris throws in the Boston. Wicked huge.
Yeah.
So as you guys mentioned, there's the conventional wisdom is that this is something that absolutely works, but that fact.
Why just go through the popular wisdom? Because I think explaining the rationale is key here
The rationale.
for why it should work.
All right. So basically, what stable angina is there is a narrowing. There's a narrowing of the coronary artery, which leads to a deprivation of blood flow and oxygen to the heart in such a way that exercise intolerance develops in an individual. So you can't walk up a flight of stairs, you get chest pain, you get heaviness, then when you rest, it goes away. So the thinking is that if you can, by placement of a catheter, put in a stent, which is really just like a rigid tube into the coronary artery where that obstruction is, you inflate it, it presses that obstruction against the wall of the artery, and then that stent remains in place.
Bracing it open.
Keeping it open, and therefore the flow of blood through that constriction is resolved, and therefore you resolve the heart being starved of blood when the demand increases when you exercise. So it makes
totally makes sense.
Total sense.
Totally makes sense.
Sounds good to me.
So there've been a whole bunch of non-placebo controlled observational studies.
No, randomized controlled trials.
That's right. I'm sorry. Randomized controlled unblinded studies.
Can you just, for the listener who doesn't know, describe specifically what unblinded or blinded means?
So what that means is that both the physician who's doing the intervention and the patient know that they are getting the intervention. They know that they have gotten the stent put in. So in the past, what they do is they take a group of patients who they treat medically and a group of patients in whom they put these stents, and they follow them for some period of time, and then they test them for their exercise tolerance. And the way
you know whether you got the drug or you got the stent.
You absolutely do, yeah, because you get sent to the cath lab and you go through this whole procedure. You get anesthesia and all the rest of that stuff. So it's unmistakable. This is like the king of all unblinded kinds of studies. So what this group of researchers wanted to do was to sort of challenge that conventional wisdom by doing a prospective interventional study that was blinded. So what they did was they basically had
How can you blind somebody to whether or not they got a catheter?
They had half of the group.
Sham surgery.
Oh.
Tell me more. Can I finish, gentlemen?
I doubt it.
Sorry, Don. Please carry on.
So they had half of the group of patients would get the actual stent put in, and the other half went to the cath lab, and everybody in the cath lab pretended like they got the stent put in, and the patient didn't know whether the stent was actually put in. So then, over a period of time, they followed these patients, and they did 6 weeks after the intervention, they did this exercise testing to see how many seconds elapsed from the beginning of the exercise situation until they developed signs of either angina or cardiac
stress in some way.
Stress of some sort, basically, they did this as a blinded study in 5 sites in the UK. They had an independent steering committee and an independent data and safety monitoring board, which we'll come back to in the second segment. They included individuals between the ages of 18 and 85 with stable angina who had a lesion in their coronary artery of 75% occlusion or more in a single vessel. And they absolutely excluded individuals with more than single vessel disease because they tend to have a worse prognosis.
And also because those people should be going to go to bypass surgery.
Right.
Whereas single vessel disease should just be stented. That's the current dogma.
Higher morbidity, higher mortality. But they did exclude people who had a lot of bad disease and a poor prognosis. And people went to the cath lab and they got this catheter, they got the angiography where they established whether there was an occlusion. And it was at that point that they that they approached the individuals for enrollment into the study.
Okay.
And there were 2 phases. So after the operation or the sham operation, people were put on intensive medical management.
Well, they didn't do the sham operation. They did the initial catheterization to prove that they had a lesion.
That was before they were enrolled. They were enrolled after after the angiography.
Right, after angiography, but not after But then they did 6 weeks.
That's what I'm saying.
Failed angiography.
But then they did the placebo versus sham operation at the end of the 6 weeks.
Right. So the 6 weeks of intensive medical management for both groups, and it was really a very unnatural situation because these people were being seen or being contacted by a cardiologist 3 times a week. That never happens in real life. So they did maximal medical management to get the stable angina under control, and these people. Then they randomized them to either get the stent or get the sham operation.
Did they get randomized even if they were able to get it under control?
Yes. Absolutely.
Yes.
Okay.
Because most of them did.
So all the staff.
What about there were 17 who were excluded, I thought, because they got it under control, was my understanding. But Betty, go ahead. Come back to that.
All right, we'll come back to that. So during the surgery, that the people who were doing the operation obviously knew what they were doing, but the patient was put under auditory isolation, so they had no idea. And all the staff in the cath lab and the angiography lab were blinded. 6 weeks later, they brought them back and evaluated them. So the primary outcome was pre-specified and was a difference in exercise increment with a bunch of endpoint events.
What in particular were they looking for in terms of outcomes?
They were looking for a prolongation in exercise tolerance in the treadmill 6 weeks after the
longer
intervention.
time being able to be on the treadmill longer.
Right.
Got it.
Right. So, and they did something called an intention to treat analysis, which meant that there were some people in the placebo group who, during the actual procedure, had their coronary artery damaged, and they needed a stent to be put in, even though they were randomized to the placebo group. So when they analyzed it, they analyzed those people who got a stent as somebody who didn't get a stent, and that's what the intention to treat.
And why do they do that?
Because that's how they set the study up, as an intention to treat analysis, and that's pretty standard for a lot of these
to
randomized controlled trials.
The benefit of randomization,
right?
Generally, which is the balanced groups. Yep.
So actually, you're right, Matt. So at the end, blood pressure was normalized. 39 individuals were symptom-free on medications, and 17 did leave the trial
prior to randomization.
Yep. So the 89% of the randomized had symptoms. There were two major bleeds, because that is one of the side effects of the medical management, because they're put on platelet inhibitors. And then as I mentioned, 4 placebo patients had an intracatheterization event. The exercise time. So the results were essentially that they found no difference in the exercise tolerance at the end of this procedure between those who got a stent and those who got a placebo. So in fact, it was a null finding.
No benefit to getting the stent. Excuse me. In terms of exercise time, anything else? Was there any benefits in terms of other things?
Which
there were some subtle ones. So, Don, you were going through the endpoints, and the primary endpoint here was exercise tolerance.
Right.
How far they can run before they get some stress. But they also had some, and then they also did some physiological measurements. So they had dobutamine cardiography, where dobutamine is a drug that forces the heart to run. So it's kind of like chemical-induced
stress test.
So chemical-induced watching hockey.
Kind of.
For example, right. That's kind of like watching the Canadiens if you're from Toronto.
You
it's
have
a lot
to
like
listen to previous
taking
episodes of the podcast
dobutamine
to
drip.
get that.
It's very similar.
That was for our long-term
listeners.
I
think one of the other things that I thought was nifty about this study was at the end of the whole study, just before they unblinded it, they asked the individuals whether they knew which group they were in. And apparently almost all of them said, I have no idea which group, whether I have a stent or whether I don't have a stent, which I thought was interesting, because it was sort of confirmation that the blinding process was successful.
Yep. Can I ask a couple of questions? First of all, I don't think you said, how big was the study? Is this a really large randomized trial, or what are we talking about here?
Not so big.
What is it?
It was 230 patients.
230 patients were, I think, randomized, and about under 200 were actually analyzed.
104 versus 90.
It was 105 and 91 in the two groups.
So
104, 90, I think.
So just under 200. And then the second question, Don. So just so that I understand this correctly, so you keep saying placebo, and you said that they go to the catheter lab, but they don't know what they got. Did they actually? So the placebo group, did they actually get a catheter inserted?
Correct.
They did.
So they insert the catheter for this person, but just don't send the stent in.
Correct.
Pull it back out.
Correct.
And didn't do anything for that
Stitch 'em up.
person. Poked a hole in somebody, but didn't do anything for them.
Correct.
Right, because one of the things that they wanted to do was to measure the severity of the stenosis, how bad the blockage was. And so the way they do that is they run the catheter into the affected artery, and then they advance a very slender probe, trying to sort of snake its way through across the obstruction. And so then you have on the tip of that you have a pressure transponder, and then further back towards where you put I guess
So upstream and
proximal.
downstream.
Upstream and downstream. So upstream, you have a pressure transducer, and downstream, you have another pressure transducer. So you can measure the difference in flow pressure on one side of the blockage to the other, therefore showing that there's a significant stenosis here because the pressure drops on the other side of the plaque, right?
Yep.
And so they did that for everybody.
Yep.
Okay. And then while they had this catheter threaded, that's when the decision was to stent or to just pull it back and go no further.
Got it.
And that decision was basically done on the table with blinding of all the the patient, of course, and all the people who were in the recovery room coming out of it. So nobody knew beyond that point. And the people who did the procedure were strictly it's literally because it's actually putting in a coronary a catheter through your femoral arteries. It's quite painful.
Oh,
it's quite painful.
Gross.
Yeah, I mean it's a big tube that goes into your thigh there to run this catheter.
Okay. All right. So both groups were blinded. Neither group knew whether or not they had actually gotten a stent put in.
And the healthcare workers who took care of
them.
them.
And the healthcare workers didn't know. So this was
the doctors, the nurses.
So nobody knew.
Very blinded.
Except for the people who actually did the procedure, because of course there's no way to blind them. But they were under strict protocol not to tell anybody what they had done. Sort of like basically have no further contact with the patient or the patient's providers beyond that time point.
Yep. Okay, so give us your take on the study. So they do this blinded trial, and they find, unlike what seems to be conventional wisdom, they find really not a lot of not any benefit to getting these stents versus just getting a tube stuck up you. What do you make of this?
Yeah, I think it's a really it's not a perfect study, but it is a very strong study. I thought their blinding was really
successful.
Impeccable. I mean, they tried very hard. The protocol, and it appears, as Don was saying, to have succeeded. Their randomization looks very well balanced, and they included a range of outcomes that spanned objectively measured data, which would not be like the patient says, I think, or I feel, or I believe, which we know from the placebo literature are the most sensitive to the placebo effects. Like, pain, for example, is very, very suggestible. So to get around that, they also included a number of objectively measured physiologic parameters, such as how much blood flow is going across these two catheters. And there, I think it was sort of interesting because if you dig into the fine print of their data, the individuals who got the stent actually did see a slightly increased blood flow, as you would expect. I mean, how could they not? So it wasn't that it didn't do anything. It did what it was supposed to do, which was to open up that artery. What it didn't do was to make the patients feel any different. And that is just like such a jaw-droppingly surprising result, because as Don was saying at the beginning, right? You've got this plugged artery, and you've got exercise-induced angina. You walk up a stairs and it hurts, and you stop, the pain goes away, and it's predictable and it's reliable. And you go to the cath lab and they find a plugged artery, and you're like, aha, there it is. So you throw in a stent, and then the patient's like, whoa, that feels much better. And the doctor's like, see, I fixed you. And everyone comes away from that convinced that this is the stent was what caused this effect. Mm-hmm. And yet the researchers were like, the placebo effect, it's crafty. We got to be careful about it because the placebo effect is awesome. And this is such an example of how powerful the placebo effect. I mean, it is really... It's like a textbook chapter case study on the placebo.
Okay, so the placebo effect being the idea that it's just doing anything. So taking a sugar pill in the case of when you're talking about something that requires a drug or maybe doesn't even require a drug, but just like you have a headache, taking a pill helps make you feel better. Whether that pill is a sugar pill or it's actually the aspirin or the ibuprofen. Just doing something. And from what I was reading, apparently there's a suggestion that medical placebos are actually more effective to depend
than surgical placebos.
Surgical ones are more effective than medical ones. That's the more invasive the sham is, the more people are effective. The mind is an impressive thing and is able to you're able to feel better by just doing something, which I think is pretty wild. Can I ask? So this was not the first study to look at the benefits of these stents. So there had previously been a study I believe it was the New England Journal. I've got it here somewhere, but I can't dig it out because I got too many pieces of paper. Which had shown there was no benefit for these in terms of these stents in terms of heart attacks and mortality.
Right.
And so the argument being made was, well, we're not doing these to prevent heart attacks or to save lives. We're doing these to reduce the pain.
Quality of life.
Quality of life.
Right.
So that's primarily what this is about. And therefore, if it doesn't actually do anything, do we need to be doing it, or is it doing something?
Right. And Don, you when you were describing the results, and you said that there was 4 patients in the placebo group who had to get a stent put in because they had intimal damage. What that means, to translate that into English, means that they had a heart attack while the stent was being inserted because the stent damaged the endothelium of the vessel and caused an occlusion.
That's bad.
And so they had to then stent it open because they had triggered a heart attack. Now, this wasn't because it was in the placebo arm. This was a function of passing that pressure catheter. Because so it could have happened to either arm. Yep. But it is a reminder that a percutaneous coronary angioplasty is not
getting a tube
benign
stuck in your artery
procedure.
It does. It does
has
have some
major risks.
Although they suggest that the risks are that this is an uncommon thing.
Sure, it's uncommon, but it's not
4
zero.
in 200 is not
that uncommon.
It's not that uncommon.
No, and I remember from my residency, a patient who died on the cath table because they caused a dissection of the coronary artery with the stent. Oh. So these do happen. Yeah. It's I think the cardiologists are very good at doing this, but this is not a zero risk procedure. And so if it doesn't actually have any benefit beyond the placebo effect, that is a game changer.
Unless a person is willing to say, I am willing to accept the placebo effect.
I don't
That's
think
a slippery slope, man.
I don't think the case is completely closed.
I don't either.
Because I think that there are a couple of things that slightly call into question the generalizability of these results. And
definitely.
And one is that there's this whole concept of small vessel disease. So that you can get stable angina because you have, in addition to that one lesion in your one artery, you've got a lot of occlusions downstream in the little tiny arteries in the heart that wouldn't necessarily be picked up by angiography. So there could have been an imbalance in the two groups, which the stenting wouldn't have helped whatsoever. So that's one problem. I think that the other issue that
why would that be different though between the two groups?
Well, it could be or it could not be. We just don't know. We don't.
No, but in a randomized trial, wouldn't we expect those to be reasonably balanced?
Not necessarily.
Well, I think I'm agreeing with Matt on this. That we would expect that those would be balanced. But I had the same thought as you, Don, but thinking about this issue of distal small vessel disease or like subtle disease that's not picked up on angiography, if you were to sort of think about the implications of this trial, the dogma has been that intervening on the big lesion is the one that's going to fix the stable angina. But if this trial is correct, and I think obviously would need to probably replicate it. It is just one study, so we should always be careful. This is one
with only
study
200 patients.
With only 200 patients, so let's not rewrite the textbooks quite yet. But supposing that they repeat this trial and they find the same result, it would kind of imply that those distal small vessel disease may be far more important in the pathophysiology of stable angina than the big vessel blockage upstream.
Yeah, sure. Right.
That maybe this in fact changes the way we think about the problem in a sort of I hate to use the word, rather fundamental way.
That the upstream lesion is really not that
important.
Right.
And that there's, these things develop so slowly that there's the collateral flow dynamics. I mean, who knows what. But there's a lot of complexity
The other point I want to make, and it's not necessarily about the methodology, but it's the take-home message. And I think it's important for the listeners and the general public to not think that under all circumstances, stents are wrong. And clearly, if you've got an acute, this was limited to stable angina. So if you're in the process of having an acute MI because suddenly you have that blockage of that one vessel, a stent is life-saving. Or if you have unstable angina because something has changed, stents can be life-saving. So we think, although nobody's done a randomized blinded controlled trial, on that. So, it is conceivable that we could be wrong about that also. But
Absolutely.
in no way do we want the
we don't have evidence.
We don't want the listeners to think that, I heard the Free Association
Don
say that the
specifically
stents were no good, and I'm just not going to go to the hospital even though I'm having a heart attack.
Well, no, because there is still therapy that can be done in any case, even if you were to.
Right.
But anyway.
But not to refuse a stent if you're in the middle of having a heart attack.
So I want to go back to, Chris, you said this trial needs to be repeated. I think there's no question, I agree with you, we need more evidence here. This is a really cool trial, a really well done trial, but this is 200 patients. This does not strike me as necessarily the only answer. And it's a specific population. These were healthier patients on average. I mean, as you said, for the reasons they had single vessel disease, they had characteristics that would suggest they were slightly healthier on average. But I'm not sure you could repeat this trial at this point now that this evidence has come out, and so I'm wondering whether or not we can actually do it. Well, let's hold on to that for the second segment. But I wanted to get to another issue, which is they followed these patients for 6 weeks. 6 weeks. That's not a long time. And if you believe that this is a placebo effect, which, by the way, I'm not totally convinced of. I mean, if you actually look at the changes in exercise time between these two groups, the increase in exercise time was about 28 seconds for the group that got the catheter, and 11 seconds increased for the
difference
group that got
16,
the placebo. So a difference of 16, but not much going on in the placebo arm. So I don't know that this is actually truly a placebo effect.
No. Yeah, I mean, there was a subtle benefit. It did not reach statistical significance here.
No, but I'm saying
there was a trend, right?
Even if you look at the placebo arm, if there was a placebo effect, you would expect the placebo arm to also have a similar increase. And they had a tiny increase, an increase of 11 seconds. Also, I don't know, is 30 seconds is what they powered the study to detect. An increase of 30 seconds, is that a meaningful change? Hard for me to believe that.
I don't know. I think it's
not
just
being a
it's just
cardiologist. It's hard to know.
I think it's just an endpoint that they can measure.
In somebody's life. Anyway.
Well, these are stable anginas. We're not talking about people having an event here.
Yeah.
So you could go up 2 flights of stairs more at the end.
Maybe. Sure. Okay. So, but they only looked for 6 weeks, and I don't know the reason why they looked at such a short-term outcome. But I have a guess, which is that if these, if you're doing a really risky trial, risky in the sense of we don't know that sticking a catheter into people without actually putting a stent in there is a good idea, then you wouldn't want to let those patients go for a long time having not gotten the stent in case you actually need to give them the stent at the end. So you'd only wait 6 weeks, which is fair enough. But if there's a placebo effect going on here, placebo effects you would think would be short-term effects. That after a while, if it's really just your mind helping you get through this particular scenario, that's going to wear off. Whereas if the stent actually does something, that's going to stay. Now, they didn't show much of anything, so I'm not trying to suggest that is true. But it does strike me that a longer term follow up would help to answer that question better.
Yeah, it's true. It's a little. I mean, none of us are cardiologists, so I think we have to be careful when we sort of wander into this field. I'm not even a doctor, right? I mean, the whole process of stents re-stenosing over time is a big problem in the as I remember from internal medicine, is a big problem in the cardiovascular field. So, but nonetheless, you know, when you look at the subjective improvement scores in terms of physical limitation and angina frequency in these two groups, you know, the improvement in symptoms is quite striking in both groups.
Yeah.
So they got very intensive medical management.
Yep.
I think that accounts for a lot of it.
Yeah, but then they had this dramatic procedure, and then they walk away, and 6 weeks later they're like, "Wow, I feel much better."
Yeah.
You know, so I mean, it is a great segue. I don't know if we can talk about the placebo effect. No.
Go for it.
No. Well, I pulled some papers that I wanted to enter into evidence because I just think that they
enter into the record.
Enter into the record.
Submit it,
Your Honor.
Okay.
Four just pithy comments about placebo.
Go ahead.
So one was a meta-analysis where they looked at pain studies, which had included an active control, a placebo control, and also a no treatment arm. And then they did a meta-analysis comparing the improvement in pain, comparing those who got the placebo versus the no treatment. So both groups got nothing.
Both groups got nothing.
And the ones who got the placebo had a 50% reduction in pain. So that, you know, is quite striking.
Yeah. I agree.
There is a beautiful study in the New England Journal of Medicine back in 2011 looking at asthma treatment, where they had patients with asthma and they gave them albuterol. Inhalers
this is an inhaler.
to release the asthma. They measured the free flow of air, showing that there's an objective physiological difference due to the albuterol, but they also asked them whether they felt better. And so they gave them placebo albuterol versus actual albuterol, and the actual albuterol significantly improved their flow, but the symptoms were identical in the placebo arm. So the placebo arm felt as improved from inhaling nebulized saline as they did from albuterol. And so I thought that was kind of striking. And then this last one I just thought was kind of jaw-dropping, was a genetics analysis looking at the potency of the placebo effect as a function of HLA of different genes. That there are some people who are genetically, yes, here we go. It is the placebo effect by Hall et al. PLOS 2012. They found
which PLOS?
I think this was PLOS 1, it would be my guess, but I'm not sure, where they had 3 different genetic haplotypes, a homozygous methylalanine, methionine, a valine methionine, and a valine homozygous mutants. And they looked at their response to the placebo as a function of these genetic haplotypes. And the ones who were methionine had the most potent responses to a placebo compared with the valines who had the least. And so to some degree, the suggestibility is hardwired.
Interesting.
Really interesting. So the placebo effect is not really is not in our minds, it's in our brains.
Okay, so I didn't get all the details there, but I think what you're telling me is that we are genetically, our susceptibility to the placebo effect is genetically different depending on...
Yeah, and it's hardwired.
Wow.
It is really a profound thought.
Okay, that's I think that, and that's the key, and that is why the blinding is so important. And I want to end with just one fun fact about this particular study. So the key to this study was the blinding, right? The fact that they took this essentially a risk and blinded people, put this catheter in so that they would feel like they got something when in fact they may not have. It was so important to get that point across. And a search of this study shows that the word blind appears 44 times in this paper. That is
that's unseen.
This is like the blind leading the deaf.
You had to go there. All right, let's move on. So in our second segment, we want to talk about ethics a little, because obviously this trial was tricky in terms of whether or not you think it is ethical to put a catheter into people when you're not actually going to put a stent into people. And I think to some people that would sound like something we really shouldn't be doing. So I want to talk about a particular aspect of ethics, which is this concept of equipoise. And equipoise is the idea that we don't, maybe you guys have better explanations, but we wouldn't want to do an intervention study on people unless we had a real balance between the idea that we think this might work versus it might not. We really have to be pretty unsure as to whether or not something's going to work in order for it to be ethically justified for us to do the study at all.
Right.
And so I want to talk about whether or not we think there was equipoise and whether or not in studies like these have equipoise in general. Before we do that, Don, can you just sort of give us a little bit of a background for the listener who is not in the field, the kind of ethical oversight that goes on in studies generally, medical studies?
So generally, there is a tremendous amount of ethical oversight. A study like this, really any study on human subjects, is required to be presented to an institutional review board. And the institutional review board's charge is really to determine whether there is excess risk that is imparted by participation in this study. And the institutional review board not only is comprised of experts, scientific experts, medical experts, but it's also it's mandated that it have a community member. So there has to be somebody from the community who doesn't have that high level of medical or scientific expertise, because that's sort of a way for the concept to be reality tested on the ground. And it's a really very, very critical part of the review by the institutional review board. So every study like this has to have that review, and that review has to be renewed every year while the study is going on. And a study like this, where it's a randomized control intervention study, needs to have a data safety and monitoring board, and that's separate from the IRB, but the results of the DSMB are fed into the IRB and their consideration. What a DSMB does is it does interim analyses. So for this study, the DSMB would be given the results part of the way through the conduct of this study, and they would be given the code as to who's blinded and who's not blinded. And they're the only ones in the study who know that, other than the people who actually did the catheterization. They do an interim analysis, and if there's excess risk in one arm or the other, they have the power to stop the study. They also have the power to stop the study if they do an analysis and the results of the hypothesis that's being tested cannot be proven by the end of the study. The DSMB can stop the study, and for the reason of futility, meaning that it's unethical to continue to expose these subjects to this intervention if the results are so close that it can't be the goals of the study cannot be achieved.
We cannot we cannot answer the question.
Right.
So the point being here that in a study like this, in any study, there would be ethical review by a body, in this case by a group that is part of the universities to which, in our case, the university to which we are part of, that reviews these looking for risk to...
And they are completely independent from the study team.
Completely independent from the study team. And it's their job to oversee that the study meets ethical standards. Which means, in a study like this, an ethical board had to have said, we sign on to the fact that this is an ethical study to catheterize somebody without actually giving them a stent. And so in order to meet that, they have to have this standard called equipoise, the idea that we consider it reasonably equally as likely for there to be no effect as there is to be an effect. Mm-hmm. The question is, do you think this study met that standard? Do you think it was reasonable? I mean, this is not the first study to do a sham procedure, right? There's a history. Chris and I were talking about this. This goes back to a study in 1959 published in the New England Journal of Medicine that randomized 13 people to get a sham surgery for angina as well. But when is it justified and when isn't it to do something like this? Because I'm not sure I would have signed up for the study if I had angina. Chris, what do you think?
Yeah, I mean, the important point is that the patients had choice whether to enroll or not, and so this is one of the.
Well, that's always
no.
It's not always the case.
They didn't in this study that I was telling you about from 1959 in the New England Journal. They had a choice. I mean, they did have a choice.
1959. We don't operate that way
No,
anymore.
I agree. But what amazed me about this study was they didn't tell them that they were going to be in a study in which they were randomized potentially to either a placebo or... They just told them they were in a study
We're talking about the 1959
study. I was shocked.
And that's huge surgery. Much worse, much more debilitating than this was.
Again, I know it's 1959, but there was wow.
So
we don't do that anymore. People have choice. There is consent forms that need to be completed.
So these people were fully informed, and they were free to opt out if they wanted to.
They knew there was a 50-50 chance that they would get nothing.
They were told that. And then the next step is that the condition they were treating was stable angina. They excluded patients who were at high risk of actually having a heart attack and needing a stent because of medical necessity, not just for symptoms, but because they were possibly going to die. And so that is an important distinction. And the second one is that they only followed them up for 6 weeks. So if we could, if, for example, it turned out that the placebo arm was not doing as well as the stent arm, in 6 weeks you can put in a stent. It's like it's not the end of the world. So it's not like they've been assigned to a pathway that is now irreconcilable, that cannot be remedied in the future. So because of that, I think actually it was ethical and not just in hindsight, because we now know that they were right for asking the question because of the placebo effect is so potent. But the fact is that the placebo effect is incredibly potent. And as you said earlier, the most potent effects are often seen in surgical interventions because the more dramatic the placebo, the more likely the placebo is to work.
Yep.
I think it's also important to say that like many intervention studies, blinded intervention studies like this, if in fact the DSMB found that there was an imbalance, that in fact the intervention was far more successful than the placebo, they would stop the study, and everybody who was in the placebo arm would be offered the benefit of getting the intervention.
Yep.
So,
but the question remains: Would you sign up for this study if you were in it? I mean, I find it hard to believe, and I tried to sort of suss this out, so I may get this wrong. So let me just try. So they enrolled 200, but they randomized roughly 200 patients, right? They were randomized between January 6, 2014 and August 11th, 2017. So it took them 3.5 years to randomize 200 patients done at 5 different sites. So you're talking about roughly 12 patients per year per site, right? This is, I mean, I think that speaks to the fact that this isn't, and you have lots of people with angina, right? I mean, this is not, it's not hard to find.
Presumably a lot of people
There's
said
probably
no
a lot
thanks.
of people eligible, and probably a lot of them said no thanks, and I can.
They say here on the flow sheet that 83 out of the 368 who were assessed for eligibility declined participation.
And but those are people who actually were assessed for eligibility. Presumably, there are other people who the study was described to them, and they didn't go through the full eligibility assessment. They just said, "Yeah, thanks, I'm not interested." And I suspect that was pretty common given the amount of time. But no, I could be wrong. I mean, it could be that just it took them a long time because they didn't have the resources to be doing this all the time because it's resource intensive to do all this blinding. But my sense is that probably a lot of people said no to this, and I think that. That gets us to a little bit into the who is in trials. It's generally people who are, healthier than the average population or healthier than the people with a particular condition. Not always. This stuff is hard to do, and I think it's ethically something that is challenging. But clearly, the results suggest that blinding was necessary, and that it without it you would not. The previous studies that didn't use blinding came to the conclusion that there was a benefit that may not actually be there. And so I wonder whether more studies after a study like this would be using sham procedures. I mean, we know they've done them for sham knee surgeries, which, as you said, is far more invasive, where they've gone in and you get just open people up and then sew them back up together. And you don't do anything. So
you're saying that the whole sort of antecedent concept of equipoise is now challenged.
I don't know that this alone does it, but I think that there have been a number of these sham studies that would suggest that we do really have to be careful about the placebo effect, and that does change the calculation a bit.
Yeah. But we have to be very deliberate about it. I mean, the whole issue of clinical equipoise is it's so complicated because what is the risk? What is the ethical risk when there is a prevailing dogma? When the community is so certain that there's a benefit, and yet the benefit is not actually there. How do you do a placebo-controlled trial? Yeah, it is fiendishly hard.
Well, so in the fields that we work in the pneumonia trials, we've often talked about would it be ethical to do a trial for treatment of pneumonia that is just watch and wait?
Not severe pneumonia.
Not kids with non-severe pneumonia, to just watch and wait, because many of those kids don't
really have pneumonia.
Or they have viral infection, in which is not going to be treated with antibiotics, but it is seen as, you have to do this. And then sometimes it's just people's feelings. We'd often talked a long time ago in the days when it was hard to get access to HIV treatment, whether it would be ethical to pay people to remain HIV negative. So every time you got a negative test, we'd get some kind of a reward. Well, people get very uncomfortable with that idea, or paying them to now in the days of treatment to maintain their treatment, because that prevents transmission onto other people. People get really nervous when you start talking about paying people, or uncomfortable. I shouldn't say nervous, uncomfortable. So anyway, I'll leave it there. But Chris, do you want the last word?
Well, I was going to say I'm reminded of a really sad example of why we need placebo-controlled, randomized controlled trials. Many years ago, there was this a very aggressive treatment for advanced metastatic breast cancer called stem cell rescue, where generally, if you have stage 4 metastatic breast cancer, it is in most cases, a fatal disease. It's almost always fatal at that point. And so standard chemotherapies had been unsuccessful at managing this. And the belief in the oncology circle was that the problem is that we can't give enough chemotherapy. So we just need to up the dose, but the patients can't survive the therapy. So there's like a ceiling on how much chemotherapy you can give. So the idea was that if we take out the bone marrow as sort of a reserve, and then we can give extremely high doses of chemotherapy beyond what would normally be tolerated, and then reinfuse the bone marrow to restore the immune system of the patient.
Yep.
And so this sort of very radical procedure was promulgated in the oncology literature, and eventually became the sort of standard practice. But it had become standard practice in the absence of any randomized controlled trials. And so there was a trial that had been started, and as the trial was progressing, the practice became standard of care. And so at that point, it became really difficult to enroll patients into this protocol because all the oncologists were like, no, this is just what we do. We have to do this. We have to do this. And so it took about a decade before they could finally complete the trial, and they found no benefit. No benefit. And so there you go. I mean, it's just like, just because it is the popular wisdom does not mean that it is true.
Sure.
So, we have to
all right.
be humble here.
All right. Well, on that note, let's move into something completely different. All right. So let's get on to our third segment, which is our amazing and amusing segment. And in this particular segment, we want to highlight some of the things that make us enjoy our jobs even more than we already do, the weird and wacky of our particular field, or the things that just inspire us. And I am going to let Chris have the first go at this time.
Sure. Thanks, Matt. Today was another paper from the Proceedings of the National Academies of Sciences, which
Somebody
is
was reading.
Stellar journal, by the way. And it is all about dirty birds. We mentioned this at the beginning.
Dirty birds.
Dirty birds.
Is that a cell phone game or video game?
No, that's Angry Birds.
I feel like you might have mentioned it 2 weeks ago.
That is the industrial era version of Angry Birds. So we have talked about greenhouse gas emissions and greenhouse contributors. Most of the attention is on methane and carbon dioxide as greenhouse gases, but
methane.
Methane.
Angina. Got it. Methane.
Where'd you get? Are you like from
Methane.
the UK or something?
Butane.
Aluminium.
Whatever. Whoever
Anyway.
Go.
So the tricky thing that there's a third major greenhouse contributor, not gas in this case, which is soot, and particularly what's called black carbon, which is soot that comes out of coal burning, essentially. So this is a common byproduct of coal burning industries in general, and we probably all remember like the moths. The white moths and the black moths who became favored because the trees that they sat up on became all sooty and black, and so now the black moths are favored and they don't get eaten by the birds because the white moths are sitting out like a sore thumb and get picked off by the birds. The truth is that when we measure soot, the only real evidence we have about soot deposits over time is the greenhouse glaciers, the Greenland glaciers. And mathematical models that have tried to explain the deposition of soot in the greenhouse in the Greenland glaciers doesn't line up with what the Greenland glaciers show.
And 3 times.
And so what they wanted to do is to say, can we provide some external empirical evidence to validate or refute the soot deposition data in the Greenland glaciers? And the way they did this was to look for another sample that was collected longitudinally over time, because our soot measurements only go back to around the 1950s.
Whose? Ours? Yours and mine?
Yes. We've only been measuring soot in the air for about the last 60 years.
Got it.
But soot's been there for much longer.
Yeah.
And so the way they did this was to look at light-colored birds.
Light-colored birds.
Which had like a white underbelly or white feathers that would get sooty. And there are a number of common species of birds that have been collected routinely for over 100 years that can get dirty. And so they did that, and they did it. They did an analysis of some very large number of birds, 1,300 bird specimens.
Old birds that have been dead for some time.
That are sitting in like people's collections with a thumbtack through them on the wall.
Got it.
Basically.
Bird carcasses.
Bird carcasses, but mostly in museums, that had been collected in the Great Lakes area and the States, where basically the Rust Belt, where most of U.S. heavy industry was going on with coal-burning power plants and coal-burning machines that were building cars or whatever they were building, but they were using coal to make heat, to drive their engines. And so they were able to use these data to basically validate that, in fact, the Greenland glacier data appear to be quite correct. And there was this really cool-looking time series analysis in this, where they looked at the sootiness of the birds, as well as the consumption of, or the burning of coal in the United States at the same time. And the two line up beautifully over time until around 1950, when the sootiness of the birds goes down, even as the consumption of the burning of coal is going up. But this was the point in time when clean coal was introduced, and when they started to insist
less sooty.
So this was clean coal, which is what home furnaces would burn to keep your house warm in the winter. They'd start to use clean coal, which is not releasing soot. And also that when they started to switch over to power plants that burned, either captured the carbon or burned clean coal as well. And then you see that the sootiness of the birds continues to go down, 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 even though the carbon emissions from burning coal goes up and up and up and up, which is, I think, sort of like beautiful that you have this sort of, proof through this sort of very backwards way, showing that these simple, well, maybe not so simple, but these interventions in terms of clean coal and the use of different technology in power plants really had a profound effect, because prior to that time, the two of them line up. There's also, I think, a beautiful story in that you see a dip in the sootiness of the birds that occurs in the Great Depression, when most of these businesses went out of business and stopped burning anything because the factories were closed.
Pretty cool.
It's just a beautiful argument. It's a beautiful little paper.
Experiment.
I think it's really important to point out that we are 3 days away from Thanksgiving, and Chris just made a very eloquent argument for dark meat.
Actually, I think you're wrong. I think you're wrong. Thanksgiving already happened.
Well, no, not for us.
No,
but for the listeners.
Thanksgiving was weeks ago. Anyway,
so this was the title of the paper was "Bird Specimens Track 135 Years of Atmospheric Black Carbon and Environmental Policy" by Shane Dubé and Carl Fuldner in PNAS.
All right,
2017.
All right, sounds good, Dom. What do you got for us?
You want me to go?
I
right.
do.
All right.
Oh, you were going to go last.
I could go either.
No, go.
All right. So the three of us had talked at some point about doing in these podcasts a review of our own papers.
Yes, we did.
So
we are going to do that at some point.
So I thought it would be appropriate to actually introduce a paper that one of us has created.
We have to guess who?
I can guess who.
I know
exactly who it is.
The name of this paper is "Gustatory Preferences for Marmite versus Vegemite Among Americans."
This is my finest paper.
Published in the Journal of Irreproducible Results.
Yes, one of the proudest
by
findings.
Christopher Gill and Paul Bolton. And so the premise for this study is to try to resolve this ongoing debate that has occurred amongst countries that are in the Commonwealth.
Going back to
1905, I think, when Marmite was first created.
Got it.
To try to resolve which is better. And it's important to know that Chris Gill has an association. You were brought up in UK, or
I was born there, but I grew up here.
But you have this very, very strong affinity for the UK.
Eating Marmite since I was a baby, yes.
Right. And the other author was Paul Bolton, who was a faculty member in our department, and he was Australian. And so they would have these raging debates during lunch or during our faculty meetings.
He wouldn't listen to reason.
And so they both decided that the only way
this is for our Australian listeners
to resolve this issue was to run a side-by-side comparison among the faculty in our department, which they did.
Full disclosure, were you involved in this trial in any way?
I was involved. I was one of the subjects of this study.
As was I.
And so what they did is they set this up as a side-by-side blinded trial with little squares of toast.
Blinded because you go blind after you eat this stuff.
On which was spread either Vegemite or Marmite.
Oh,
and
butter.
There was a quantitative and a qualitative aspect to the study, and the quantitative aspect, essentially the bottom line was that
they are both
all of the
disgusting.
Americans could not discern a difference between Vegemite and Marmite, and all of the Americans found them equally disgusting.
Yes, that is so right.
And there was a scale that was used for figuring out what the quality of the appearance, smell, taste, and after flavor of Marmite and Vegemite were.
Spelt with British spelling, by
And
the
it
way.
Well
went,
done.
for appearance, it went
Didn't
from
know you knew.
enticing to induces a fight or flight response.
Yep.
The smell was deliciously aromatic or worse than smelling salts.
That
For
sounds right.
taste, it was mighty good versus emetogenic, which means it induces
I don't know what
vomiting.
okay, there you
After
go.
flavor was tantric ecstasy versus like something died in your mouth.
I'll go with the last one.
So, anyway, and then
I
there
had
was
a lot of fun with this
there
one.
was another scale which went from god awful ferment of the bounty's bilge,
What?
like arthropod jelly on toast, concentrated pond scum, miasmic effluent, or nectar of the gods
I
ambrosia.
can tell you it's not that last one.
So I was I thought this was a brilliant piece of work, and I thought it was
Well done, Chris.
it was really pushing the barriers far. But
bounds.
then I went into the literature and I found out that there are apparently 75 other comparison trials between Marmite and
Wow.
Vegemite. And in fact, there's also a New Zealand version of Marmite. And
Really?
when the New
really.
Zealand earthquake happened in Christchurch, the factory that makes the New Zealand Marmite closed down, and the people in New Zealand apparently freaked out when they called it Marmageddon. Apparently, Marmite is the world's most polarizing spread. But
Yep.
the most interesting thing that I want to point out is that there is a Marmite gene project where
Say what
a
now?
specialist genetics company called DNA Fit has determined what is the genetic predisposition of whether you love or you
Oh,
hate
come on.
Marmite.
This is like the anosmia.
And apparently they've looked at single nucleotide polymorphisms, and they've associated it with whether you are a Marmite
You've got to
lover
be kidding.
or hater.
And so Americans don't have that.
And it turns out
Americans are
that
the
you
haters.
can, for 89 pounds, you can get your gene, your genetic makeup sent in,
Yep.
and they will determine whether you are a lover or a hater. And what they say is that it turns out that preference for Marmite is genetically predisposed. And the report that they put out say, secondly, Roos explains, and with some serious quote, that lovers and haters can coexist in the same family.
Really?
Even if two parents are haters, they can still have a love child.
Oh, that is just terrible.
Well, I'm so happy to hear that. And did you know
It was
that,
a brilliant piece of work,
That's
Dr.
real.
Gill.
Thank you.
Well done.
Did you know that the Prime Minister of New Zealand, when that earthquake came and destroyed the Marmite factory, went on the radio and said, "Do not panic. We will import Marmite supplies to keep you going. You will not have to eat Vegemite."
Oh, that is scary. All right. There you
There
go.
was concern about this matter.
All right. Well, so I went, as usual, in a completely different direction. I'm going to tell you about an
Are you going
article.
to tell us another story about how anxious you get when you submit articles or abstracts?
This
or-
one I don't have to, but yeah, I had other ones, and I decided not to go in that direction because that is generally. I had another one that was perfect for that, but no, I'm not going to. So this was an article that was written in Science News back in 2015, July of 2015, by Tom Siegfried, which the title of it is 10 Ways to Save Science from its Statistical Self. And it's a very, I think, thoughtful article on some of the problems that have come out in science for some of the reasons that we either have or have not talked about, but as you know, they annoy me. Some of which, are things that make a lot of sense. So things that deal with just the problems with hypothesis testing and p-values, which I've told you about, better textbooks for teaching statistical sciences, rethinking media coverage of science, which is something that I agree with. Number 10 is definitely one of my favorites, ban p-values, which, I am and rethinking confidence intervals. Great. And emphasizing estimation. But the one that is my absolute favorite, even though I'm not sure it's a good idea, is number 6. Create a journal of statistical shame. So I'm
like
not
a
sure this
pea
is
wall of shame.
I'm sure this is a terrible idea. I'm sure that if they ever started one, the Vegemite study would end up in there. But I loved it as a thought idea. Let's hope it never actually happens. So that brings us to the end of our program. If you've got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you could tweet us at PopHealthyX or tweet me at ProfMattFox, or you could tweet Chris at id.gill or Don at dthea1. Or you can find us at the Population Health Exchange website at www.pophealthyx.org. We want to thank Leslie Talalian, Director of Lifelong Learning at BUSPH, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you download our next episode.
Next 10 episodes.
Next 10 episodes.